Prostatitis is the topic for this video, and the itis should be a clue that this is of course talking about inflammation and inflammation of the prostate gland. And prostatitis can be bacterial or it can be non-bacterial, and if it is bacterial, it's affected by the same bugs that cause urinary tract infections. So that kind of helps you remember, same as the UTI bugs, which include of course the famous E. coli and other bugs as well, like Klebsiella, Proteus. Now let's talk a little bit about symptomatology. The symptoms involved in prostatitis are actually urinary in nature initially, which include frequency of urination, going to the bathroom quite a bit, urgency of urination, and also going to the bathroom at night, Nocturia. And this is essentially because the prostate, once it's inflamed and enlarged, it compresses on the urethra. So the urine that normally sits in the bladder has a difficult time coming out of the bladder into the urethra. As you can see here on this part of the diagram, when the prostate is normal size, there's no compression, but once you have inflammation, that compression is illustrated here. Now if you go back to the symptoms and you talk about a case of prostatitis that has become chronic, you tend to move into pain. Now pain can be in existence even in an acute case of prostatitis, but chronic cases of course kind of linger with very unfortunate symptoms such as lower back pain and pain in the perineum. And also patients will complain of pain with ejaculation in cases of chronic prostatitis. Now, some of the symptoms are of course very nonspecific, like fever and chills, but one thing that definitely is not nonspecific, it should really alert you, is the physical exam, and what I'm really referring to is a rectal. Now, the rectal, of course, is to be done gently because the prostate is very tender. And also another thing, when you do the rectal, in addition to definitely sensing that the prostate is very tender, is that the prostate will also have a boggy consistency. Boggy is sort of a term that kind of describes the prostate to be a bit squishy, and that kind of goes along with the fact that it's inflamed and swollen. So diagnosis, of course, involves the physical exam, the rectal, which of course should be done gently, and then really same type of test that you would do to diagnose a UTI, the urine analysis. The urine will show white blood cells, and if it is indeed a bacterial cause of prostatitis, you can isolate the bacteria. And in severe cases of prostatitis, you may also need to do blood cultures as well to isolate the organism if there is a bacterial etiology. Treatment of prostatitis essentially can be broken up into acute and chronic. There's a lot of overlap between the two. Acute cases of prostatitis are commonly treated with fluoroquinolones, in particular the very famous ciprofloxacin. If the patient is allergic to cipro or allergic to any type of fluoroquinolone, then you can use sulfa drugs such as trimethoprim sulfamethoxazole. One thing I wanted to mention with this drug is that it's a sulfa drug, also known as a sulfonamide, and sulfonamide drugs are to be used with caution in patients that have G6PD because they can cause hemolytic anemia, and that kind of is a important point that shows up on exam questions. Just keep that in mind. Now, in the chronic situation, of course, same type of medications, if it is indeed bacterial, fluoroquinolone. Anti-inflammatory drugs can also help. And another medication that can be used is an alpha blocker. And what alpha blockers do is they help dilate that urethra that has been compressed because of the inflamed prostate. So this urethra right here can be dilated with the help of alpha blocker medications. So let's take a look at a few vignettes. 39-year-old male with a 20-pack-year history of cigarette smoking presents with fever, chills, and painful urination. On physical exam, his prostate is boggy and exquisitely tender on palpation. A urine analysis reveals white blood cells and gram-negative rods. This man's symptoms are most likely due to which of the following? Gram-negative rods, most likely probably E. coli. This is a very classic vignette that describes prostatitis. Now they've given us some choices here, acute, chronic. Well, if it's gram-negative rods, then it's bacterial, so it's not abacterial. So now we have to choose between acute and chronic. Well, obviously the difference between acute and chronic is the time span. This question doesn't really tell us much about if this is recurring or if this is a one-time acute event. But one of the things that kind of you can differentiate is sort of the urinary symptoms being predominant in his presentation, which kind of makes you think or lean toward acute, whereas if his symptoms were more about lower back pain and chronic pain of that nature, then it would probably make you think more of a chronic case. Next question. 67-year-old black man with a history of G6PD deficiency presents with fever, irritative voiding symptoms, and perennial pain. Rectal exam is remarkable for a boggy, exquisitely tender prostate. Urine gram stain is positive for gram-negative rods. The risk for developing hemolytic anemia is highest if he receives high-dose 21-day therapy with. Well, let's backtrack here. What is this question talking about? Well, first and foremost, the patient has prostatitis, right? And he's got G6PD, so that you have to be careful about that you don't give him the wrong medication. Now, normally prostatitis is treated with medications that will kill the bacteria. For example, in this case, he does indeed have bacterial prostatitis. Fluoroquinolones, sulfonamide drugs like TMP, SMX, trimethoprim sulfamethoxazole. But in this case, you don't want to give this medication because it's a sulfonamide drug. In G6PD patients, if you give a sulfonamide drug, it can cause hemolytic anemia. And that's what the question is asking. Which medication essentially should you not give? And the answer, of course, is D. And finally, 55-year-old man comes to the emergency department with pain on urination, fever, and chills. He also complains of perennial and suprapubic tenderness, as well as dysuria and hesitancy. His allergies include codeine, sulfonamides, and quinidine. Temperature is 38.5, blood pressure is 132/90, pulse is 88, and respirations are 18. Abdominal exam is remarkable for suprapubic tenderness. A rectal exam demonstrates a swollen, boggy, and exquisitely painful prostate gland. Lab studies show leukocyte count of 11,500, creatinine of 0.9, BUN of 16. UA shows too numerous to count white blood cells, and gram-negative rods. Most appropriate treatment for this patient is. The clinical vignette obviously describes a case of prostatitis. And fluoroquinolones and TMP, SMX are some of the more common antibiotics used. He's allergic to sulfonamides, so you can't use choice E, so that one's out. So the remaining choices, the best one is ciprofloxacin.